Welcome. I'm Dr. Beth Frates, clinical assistant professor at Harvard Medical School and a certified trained health and wellness coach. My main area of interest and my passion in my career is lifestyle medicine. Health and wellness coaching is critical for behavior change. I'm going to share my screen with you and share some slides. Today we're going to go over health coaching theory and research. My disclosures are that I have a wellness coaching private practice called Wellness Synergy. I'm on the scientific advisory board of Jenny Craig, and I am on the medical advisory board of Obvious Solutions. Our goals together are to recognize the main behavior change theories used in research studies, to identify behavior change techniques from systematic reviews of the literature that are effective techniques, and review the health coaching literature together. Let's start off by looking at the experts in the field. The Offices of Behavioral and Social Sciences Research at NIH, we have Dr. Karen Glantz. She's at University of Pennsylvania, and her areas of interest are specifically behavior change, social and behavioral theory. She has an excellent e-source document available, and she has been cited in the top 0.5% in her field. The e-source is titled Theory at a Glance, a Guide to Health Promotion and Practice. So here's someone who's been in the field for many years and is an expert. We're going to look at the most important theories behind health coaching. And the first is the health belief model, also HBM, considered in short. So we have modifying factors, we have individual beliefs, and we have action. So the modifying factors that affect us are age, gender, ethnicity, personality, socioeconomics, and our knowledge level. And then what's critical is our individual beliefs. Perceived susceptibility to and severity of disease, and the level of perceived threat that we feel. Our perceived benefits to adopting a new behavior, perceived barriers for adopting a new behavior, and then our own perceived self-efficacy. Can we do this? Can we make the change? And this is what leads to individual behaviors and cues to action. So this is the health belief model, focusing in on our own beliefs, realizing that we have modifying factors and influences in our life, and ultimately we need to lead to action. But it's these beliefs that are leading to our action. Another critical model, the trans-theoretical model of change. We have pre-contemplation. These pre-contemplators are not ready to change, and they are not willing to even consider it. Then contemplators, who are thinking about change, and then preparation, those who are planning for change. They have weighed the pros and cons in contemplation. They've determined that changing is for good, and then we get into action after preparation, and the new habits have been adopted. They've been practicing them, and after they've been practicing these new healthy habits for 6 months or more, they're in the maintenance phase. Now, as you may realize, you don't necessarily go 1, 2, 3, 4, 5 around the circle and stay at maintenance forever. Sometimes you may be in maintenance and you may slip back into preparation, depending on what's going on in your life. James Prochaska at the University of Rhode Island created this trans-theoretical model of change and has written extensively about it in his book, Change for Good, and also his own website if you'd like more details. And it's all about trying to tailor our interventions, our behavior change counseling, to meet the needs of the individual patient in front of us. Next theory that's critical, important in literature and research is social cognitive theory, where we have the interplay between these three major forces: the personal factors, going on in our own lives, our behavior, and our environmental influences. These three things play off each other every day and all the decisions that we make. And when we're working on behavior change and we're helping patients to adopt and sustain change, we need to think about their own personal factors, what's going on with them, the behaviors they're exhibiting, the habits that they're in, and also what are the environmental forces around them that may be shaping their behavior. Talking about forces around the individual, we can't just consider the individual when we're counseling. The social ecological model of change points that out and highlights this. We often meet the individual in the clinic and we are approaching the individual looking at their knowledge, their attitude, their skill level. We can do this and be successful for a little while, but if we don't look outside the person at their surroundings, at the influences around them, we won't get sustained, lasting change. We need to look at interpersonal, social networking for that patient, for their friends, their family. What are they doing? What are their habits, their spouses, their best friends, their colleagues at work? Look at the organizational level, the environment around them, perhaps their neighborhood, where they live, where their house is located, what grocery stores are around them, if there is the option for gardening, if they are able to even get outside and feel safe for exercising, what is their environment? Then the community, what are the cultural norms? What are the cultural values that are surrounding this individual? We must take these into account. And then government and public policy has a big influence on how people behave. When Dr. Glantz looked at all the literature, this is the esourceresearch.org document that I was talking about in the beginning. She reviewed all the literature from years ago and tried to figure out what theories were used most often. And as it turns out, they are the ones that we have reviewed. When people were looking at dietary fat, fruit and vegetable consumption, the theories often used were social cognitive theory, goal setting, social support. And another important topic, mammography promotion in underserved groups. The theories used in 68.4% of those studies were health belief model, trans-theoretical model of change, social cognitive theory. Looking at unintentional injury prevention research, again, the theories that were used were health belief model. The trans-theoretical model of change, health belief model, also used with tailored print health behavior change interventions. So as she reviewed all the literature and the theories that were used in the various studies, she came to find that it was the theories that we just reviewed, which were most commonly cited in the literature as those used for behavior change. And as you know, behavior change is what a health and wellness coach does. Health and wellness coaching is all about changing behavior, empowering people to change. Now, I got into medicine because my father had a heart attack and stroke when I was 18 and he was 52, and I wanted to learn everything about how to prevent a heart attack and stroke. Got all my knowledge, went into physiatry, physical medicine and rehab, completed my residency, and got into research on nutrition, exercise, stress resiliency, and really forged the way here at Harvard at the Institute of Lifestyle Medicine for the specialty lifestyle medicine. We started the Harvard Institute of Lifestyle Medicine in 2008, and now 12 years later, it's going strong with CME courses. It's primarily an educational institute, but you may be familiar with the American College of Lifestyle Medicine. I was fortunate enough to be elected to the board of advisors for that. and board of directors, excuse me, for the American College of Lifestyle Medicine. Served there for 3 years and really helped to move the field forward with national leaders and experts, and it was an honor to be part of that. An important piece of my lifestyle puzzle, part of my journey, is my early adoption of health and wellness coaching, and I was one of the first physicians who completed health and wellness coach training back in 2008, and I have done 4 health coach trainings since that time, as well as motivational interviewing certification. When I started in 2008, I'm here at Harvard. As I mentioned, I needed to go to my department chair and tell him that this was going to be a focus of mine, behavior change and health coaching. So I went right to the literature back in 2008, and I was hoping to find some randomized controlled trials, our gold standard. And indeed, I found 13 back in 2008. There were 13 randomized controlled trials available for my review. There was a non-randomized trial I found, some qualitative reports, a case study, project demonstration, a lot of descriptive articles. What is health coaching and what could it do? There are about 7 of those. And then there were even 2 articles that looked at health coaching in medical education. I want to highlight for you in this talk on health coaching research some of the seminal, the early, powerful studies that helped put our health coaching profession on the map. So Vale and colleagues looked at 792 patients with cardiac disease. There was a coaching group and a usual care or routine care group in all of these studies that I'm going to share with you. And they were randomized. These are all randomized trials. So the cholesterol dropped more significantly in the coaching group than in the routine care group, 21 points versus 7. Whittemore and colleagues looked at 53 women with diabetes and didn't look at numbers, but looked more at behaviors. So with the women who were coached versus those who had usual care, there was better diet self-management, less diabetes-related distress, and higher satisfaction with care in that coaching group. Ruth Wolliver, who was at Duke and has moved to Vanderbilt, has done a lot of research on health coaching, and in one of her studies looking at the type 2 diabetics, 56 of them, she did look at the numbers. She found a significant reduction in hemoglobin A1C among subjects with a baseline that was greater than 7. That was coaching compared to routine care. Coaching's also been looked at for parents and children, specifically coaching the parents of children who have asthma. Fisher and colleagues completed this study looking at 191 children, and their outcome was decreased hospitalization rate. So that gets to the money and the ROI, the value that health coaching can bring to the healthcare system. So those that were coached, those parents and children that were coached, had a decreased rehospitalization rate compared to controls, 35.6% versus 59.1%. And that was statistically significant. Interestingly, Oliver and colleagues looked at cancer patients, 67 of them, and they looked at just one coaching session, one intervention before the patient was going to go to the oncologist for pain. And the coach met with the patient, talked about ways to discuss pain and pain management with their physician. And the other group was simply waiting in the waiting room, no intervention. So this is coach versus routine care. And there was improved pain severity compared to control. This was looking even weeks after the visit. So these were the really first landmark studies for health and wellness coaching. They were seedling studies, but they did show that health coaching could lead to improved health outcomes in cardiovascular disease, diabetes, cancer, pain, and asthma. Now, there were lessons to be learned from these seedling studies, the limitations, small sample sizes, lack of consistency with coaching specifics, lack of long-term follow-up. There's nothing 3 years out or 5 years out. But what I was really interested in when I was reading very carefully through these studies was, how was coaching described? What was the methodology? And what were the common threads? I wanted to know the magic behind health coaching. I saw that there's evidence that it can work. And when it was working, what were they doing? So the common threads I found was one-on-one relationships were key. There was always collaboration and negotiation mentioned. There was goal setting in every health coaching study, and accountability was set in these studies. Now, a lot has happened since then, since 2008, 12 years ago, when I first looked at these materials. And by the way, you can find the references for all of those studies in an article that I wrote in the Archives of Physical Medicine and Rehabilitation, which I'll point out to you later. So keeping up with the literature is something we do as physicians. You want to know, what does the recent data show? What is effective? What are the common ingredients of effective programs? What counseling strategies based on behavior change theories work? What behavior change techniques, strategies, and tools work? So the counseling strategies, behavior change techniques, we're looking at health coaching and the process of health coaching. So I'm going to share with you some research on these techniques now. So we're looking at effective strategies and tools for nutrition counseling and helping people adopt a healthy habit. So cognitive behavioral therapy shows good outcome. Motivational interviewing shows good outcomes. Self-monitoring. So a coach helping the patient to monitor and log their meals. Now, meal replacements and structured meal plans tend to work for this as well, nutrition and diet counseling. But look what we find, things we've already talked about: goal setting, problem solving, and social support being key in this research article around what is effective nutrition counseling. How can health and wellness coaches be effective? How can lifestyle medicine practitioners be effective in their counseling? So let's also look at what's ineffective. This is from research. Compelling evidence exists to demonstrate that financial reward strategies are not effective. When we look at specifically retirement age and nutrition information and counseling, effective ways to increase fruit and vegetable consumption, barrier identification, and then helping problem solve. It's a big part of health and wellness coaching is problem solving, identifying barriers and finding solutions around them, planning social support and goal setting, use of follow-up prompts, providing feedback on performance. So letting them know they did a really good job at the grocery store, purchasing the kale, purchasing the carrots, purchasing the sweet potatoes, and giving them some feedback on how it's going. When we look specifically at the diabetic population in terms of physical activity and diet, there's a review of the literature from 1975 to 2015, and 14 randomized controlled trials were included looking specifically at behavior change techniques that were effective. Those that were effective behavior change techniques were instruction on how to perform a behavior, rehearsal, demonstration of the behavior, and action planning. This is again for diabetics who were working on physical activity, exercise, and diet. So strategies that worked were supervised physical activity, group sessions, contact with an exercise physiologist, contact with an exercise physiologist and dietitian. So the dose that was deemed, how much do we need? Greater frequency, intensity of sessions helped. How much health coaching, how much behavior change counseling do you need? That's a great question that's still yet to be answered specifically for all populations. But what most research will show, as you see here, greater frequency and intensity of sessions, the better the outcome. So now we're looking at adult patients with obesity and how to increase physical activity. First thing is increase self-efficacy. And how do we do that? Action planning, helping with time management, prompt self-monitoring of behavioral outcome, and planned social support. Having social support and engagement is critical. How about increasing the behavior? Not just the feeling that they can be successful, but increasing the actual physical activity. prompt self-monitoring of behavioral outcome and plan social support. Again, having the social support and self-monitoring. Teaching the use of prompts and cues, triggers, prompt practice and prompt rewards, contingent on effort or progress towards the behavior. Not just rewards for reaching the goal, but for effort and for progress. In terms of overweight and obese individuals with physical activity and nutrition, another study looking at a similar population, effective behavior change techniques in the short term were goal setting, self-monitoring of the behavior, and then effective behavior change techniques in the long term, same too, goal setting and self-monitoring, but also in the long run, feedback on outcome of behavior. So seeing that when people lost weight, their blood pressure went down, their hemoglobin A1C went down, their inflammation went down, perhaps their cholesterol went down, checking in on that. And in fact, even looking at a timed mile and seeing if they improved their time. That helps too. Implementing graded tasks, so setting small goals and keeping going with that. And adding objects to the environment, using a step counter, a portable peddler, helping, again, to create an environment for success. So it's the individual and it's their beliefs, but then it's also what's around them and how do we empower them so that they can be successful. Effective counseling strategies to help maintain behavior change over time. Autonomy, supportive, person-centered, motivational interviewing works. So appreciating that these are adults and they want to make their own decisions, that will help over time. Asking them, what do you think will work best? Joining the YMCA, getting the portable peddler, what would you like? And that's all what health coaching does. It doesn't tell people what to do and wag the finger. It negotiates, collaborates, as we said, with the patient. Problem solve around barriers. And to let patients find their answers. They often have thought about their issues, their past progress, their past failures, and they have a pretty good idea what it will take for them to be successful. And the health coach helps pull it out and helps them keep their autonomy. Let's talk about behavior change and weight change in adults. The best predictors of beneficial weight and physical activity outcomes: higher autonomous motivation. So the patient wanting to do this for themselves. Higher self-efficacy, higher self-regulation skills. And you can get there through self-monitoring. For weight control, positive body image, flexible eating restraint. Now, when we look at children, we looked at the elderly, we're going through the span of life here, and focusing on children with obesity and changing their physical activity and eating. Effective techniques for management interventions, so they already have obesity, versus prevention interventions. So for management, providing information on the consequences of behavior to the individual, environmental restructuring, prompt practice, prompt identification as role models, position advocate, having stress management and emotional control training is very important for children, so they don't just go to food when they're stressed. And then general communication skills training for children, helping them communicate what they need when they're hurt, how they can solve a problem on their own or with the help of family, friends, parents, teachers. Now for prevention, prompting generalization of a target behavior. So if it's physical activity levels and exercise, hoping to get them to understand we want to do this in school. We also do this at home during the week, during the weekends, generalize the importance of the behavior. So healthy eating, it's not just for school time or just for weekends. Healthy eating is morning, noon, evening, snack time, and help the children see the value of that. It's important also to know about ineffective techniques for children with obesity when you're trying to help them manage the obesity. Providing information on the consequences of the behavior in general is not helpful for the children. So to say, if you're obese, you're going to get diabetes, you're going to have high blood pressure, you're going to maybe get inflammation and heart disease, this doesn't help children. In terms of ineffective techniques for prevention, providing information on the consequences of the behavior in general, doing that, threatening children that if they eat excessively, if they don't exercise, they will be obese and they will have all these health problems. This doesn't work for the children. Providing rewards contingent on successful behavior doesn't work. Facilitating social comparison. Oh, look at what Susie's doing. Look at what James does and how fit James is. His routine is this. That doesn't work. Now, those are the counseling strategies that we see effective, and health coaching uses those strategies that are effective and looks at that type of data so that health coaching can continue to be a powerful tool for health coaches, for lifestyle medicine practitioners, primary care physicians using health coaching conversations for behavior change. Let's look at some literature that evaluates the effect of health coaching specifically. So this is the effect of diabetes health coaching in individuals with type 2 diabetes. And this is a review. When I first looked at the literature, there weren't review articles or as many. Now there are several, looking at 8 different trials, 724 subjects, health coaching versus control. Pooled the effect of health coaching overall was statistically significant with a reduction of hemoglobin A1C levels by 0.32. Longer health coaching, greater than 6 months, resulted in a greater reduction of hemoglobin A1C levels compared to shorter duration. And then diabetes health coaching consisted of, in this study, goal setting, knowledge acquisition, individualized care, and frequent follow-up. Another study that looked at coaching on stress and specifically cortisol levels. And they looked at mothers of young children. It happened to be a randomized controlled trial in Japan. 74 mothers with a median emotional intelligence scores or lower were the subjects. The intervention was 3 months of coaching, how to manage stress, how to work collaboratively and negotiate with children. The intervention group had lower salivary cortisol levels and a greater improvement in emotional intelligence scores by the end of the study, the 3-month coaching program. And this was comparing women with the coaching versus without. Now, health coaching on COPD rehospitalization. You'd heard about rehospitalization with asthma. COPD is another respiratory disease which is marked with frequent hospitalizations, and lowering that for the patient as well as for the price tag and healthcare is important. So in this study, 215 patients were hospitalized for COPD, chronic obstructive pulmonary disease, exacerbation. They were randomized into a motivational interviewing-based health coaching plus written action plan for exacerbations and brief advice on exercise versus usual care. I want to focus here. They just had brief advice on exercise, but they had MI-based health coaching for exacerbations and a written plan for exacerbations. They measured the COPD-related hospitalizations over the following year, and absolute risk reduction of related rehospitalization by health coaching was 7.5% at 1 month, 11% at 3 months, 11.6% at 6 months, and then 11.4% at 9 months, 5.4% at 12 months. So it did go down. All were statistically significant except for at 12 months. Quality of life scores significantly improved in the coaching group at 6 and 12 months. There were no differences in physical activity between the two groups, the usual care and the group that got brief exercise advice, because that's not coaching. Giving advice is not coaching. So that was not comparing coaching. It was comparing giving advice. Here's another health coaching review looking at diabetes. It's a very common one because, well, we have a diabetes epidemic here in the U.S. and it's global as well. Personal health coaching as a type 2 diabetes mellitus self-management strategy. This was a systematic review and meta-analysis of randomized controlled trials. 22 publications were in this review. And it turns out, the conclusion is, personalized health coaching appears effective in improving glycemic control after reviewing the 22 publications available to those interested in health coaching and diabetes. Now, not all of the studies on health coaching have shown positive results, and I'm sharing health coaching in the rehab setting with you from 2017 in patient education and counseling. So there were 90 randomized controlled trials, but only 14 were rigorous enough to be included. There's a high number of studies, which actually underlies the relevance of this approach and how much more common this health coaching is in the rehab setting. 6 studies proved statistically significant in the long term, so 6 of the 14, so not all of them. So this systematic review reported there's a research gap that exists in regard to the long-term effectiveness of health coaching in the rehab setting, and more research needed to be done. Not only do we look at randomized controlled trials, although that's what I've been showing you. I was involved with a publication in the American Journal of Lifestyle Medicine in 2018 that was a compendium of health and wellness coaching literature. 219 articles were collected, and only 150 were rigorous enough to be in our database. We reviewed prospective studies, retrospective studies, longitudinal studies, case studies, yes, randomized control studies, randomized studies, and case demonstrations. We reviewed all the literature and looked at what the outcomes were revealing. And our summary is, the compendium results summaries point to health and wellness coaching interventions as a treatment adjunct worthy of consideration for cancer, diabetes, and heart disease patients. Lastly, and interestingly, thinking about coaching in the primary care setting, so coaching the physicians. So this was a cross-sectional study from 2008 to 2011, and the intervention group was coaching, which consisted of guiding family doctors to improve their clinical abilities. So control was family doctors not participating in the coaching intervention, and coach was a medical doctor trained in skill building, experiential learning, and goal setting. That's who was coaching these primary care family docs. Coaching of the family docs increased the possibility of patients reaching the fasting glucose goal by 1.4 times. The difference between the two groups increased over time. So this is to say, we coach our patients, but guess what? We can also coach physicians so that they can become better coaches and better at behavior change counseling, which will help us with lifestyle modification. Here's the article that I wrote in 2011 that described the landmark studies for health coaching back in 2008 when I first dug into the literature, the American Journal of Physical Medicine and Rehabilitation, 2011. I want to leave you with a 5-step cycle for coaching. We talked about the literature and research around behavior change techniques, about health coaching and the health coaching trials that are out there. I want to tell you, after all the research and all the trainings that I've done, a 5-step approach for you to embrace if you'd like. First step, when you see a patient, is to be empathetic. Try to see things from their point of view, then align their motivation, not yours, but their motivation. Find out why they may want to start exercising or change their diet. What is motivating them at this time? Then build confidence, find out what their strengths are when they've been successful in the past. Then set SMART goals, specific, measurable, action-oriented, realistic, and time-sensitive, small, smart goals so that they can be successful. Success breeds success. And after you set goals, you must set accountability. Check in on the patient. Make sure the patient has an accountability partner, a buddy, so that they can stay on track. And then when you meet that patient again, you meet them with empathy. You go along the same 5-step cycle. I hope this has been helpful. I hope the literature I shared is useful to you, and I hope that you will be able to see and feel the beauty of health coaching. Thank you so much.